Welcome to AETCM, the emergency medicine channel. Today let us discuss about megaloblastic anemia. So megaloblastic means, that word meaning is, so normally if you see the RBCs are like this is a size. Megaloblast means RBC size will increase. Microcyte means RBC size will decrease. So that is megaloblastic anemia. Okay, the cells are immature cells are produced more, and they are large in size comparing with the normal blood cells, but they are functionally not as good as a normal RBC. The size is large, but the function is not that good. So patient develops anemia. Okay, that is megaloblastic anemia. Oh, now we know that bone marrow produces RBCs. Kidney produces erythropoietin. So erythropoietin helps in production of RBC, and for that we require iron, folic acid and B12. Okay. Iron deficiency produces small RBCs, that is microcytic anemia. Folic acid and B12 deficiency produces large cells, but functionally they are inactive. So that produces megaloblastic anemia. Okay. Erythropoietin reduced in chronic renal failure can also produce anemia. Bone marrow production reduction due to any cause, including B12 folic acid deficiency, also can produce anemia. Now, macrocytosis is a descriptive term for RBC size larger than normal. So that is very important. RBC size is larger than normal cells. RBC size on peripheral blood smear is estimated by comparing RBCs to the nucleus of a small lymphocyte. So that is a normal small lymphocyte nucleus will be the size of RBC. So if it is more than that, you can call it as macrocytic RBC, large cell. So when there is macrocytosis, mean corpuscular volume will be increased. So this will be the easiest investigation which can tell you what is the type of anemia. So in normally MCV can be normal, but when the cell size is larger, MCV will increase, and when the size is smaller, the size will be decreasing. Okay, so anemia itself can produce differentiate with only with MCV, normal MCV anemia, high MCV anemia, low MCV anemia. We are discussing high MCV anemia. So megaloblastic anemia or macrocytosis will produce elevated MCV. That will be the easiest investigation in a given patient who can be diagnosed as megaloblastic anemia. So megaloblastic anemia, MCV will be elevated. We will see the causes for that. So increased size of RBC is the classical presentation of megaloblastic anemia. So that is due to the maturation defect in RBC. So B12 folic acid can reduce the maturation. That is the commonest cause, but there are so many other causes also be there behind megaloblastic anemia. So nucleic acid metabolism is impaired here. That is a major cause. It can be due to various reasons, but most common cause is B12 and folic acid deficiency. Now, cause of megaloblastic anemia, the first cause and most common cause will be B12 deficiency, cobalamin deficiency, or cobalamin absorption or metabolism abnormalities. So B12 absorption and metabolism defects can produce deficiency, anemia. Next one is folic acid. Folic acid deficiency, that also, or abnormalities in folate metabolism. Methotrexate is an anti-folate medication that can produce folic acid deficiency. That's why we always give folic acid along with methotrexate. But if folic acid is not given or patient has not taken folic acid, he can develop megaloblastic anemia, neutropenia. Then folic acid is the treatment, not folic acid. Some causes acute myeloid leukemia, myelodysplasia also can produce a megaloblastic anemia. Therapy with various drugs can also produce folic acid anemia. Thiamine responsive megaloblastic anemia means once you give thiamine, it will be reverted. That also seen in some patients. But the commonest cause is B12 and folic acid deficiency. In that, B12 will be the most common. Now, if you when we are talking about B12, we should know the source of the B12: meat, fish, egg, and milk. So those who are not taking meat and fish or egg, they have high chance of B12 deficiency. But if you are taking adequate milk and milk product, that can be covered up. So whatever it is, if the diet does not contain B12 from any of these sources, then patient can develop B12 deficiency. Sometimes there will be intrinsic factor antibodies. B12 is absorbed in ileum by intrinsic factor secreted by parietal cells. So antiparietal and antibodies in patients can produce sometimes B12 deficiency. You can see here B12 is taken by this intrinsic factor inside. So B12 deficiency can produce various clinical features, like one is megaloblastic anemia, other one is subacute combined degeneration of nervous system and dementia, optic atrophy. So these are neurological problems because it affects the nerves and brain cells. It also affects the maturation of RBC. That's why you get megaloblastic anemia, large cells. Now, maturation process, if you see the megakaryocyte, then from there it will become RBC. So this is a maturation phase. So you can see here this is a maturation phase. If there is a problem somewhere here or here, that maturation will be arrested here. So the cells will be larger than the normal cell. Normally the RBC will stay for up to 120 days in our circulation. But if there is a destruction, rapid destruction in peripheral also, you can get larger cells. There is a continuous destruction, increased peripheral destruction. Before the RBCs are matured, it will be distributed to circulation. There also you can get. But here we are talking about something which can produce arrest in the process. Now, B12 is very important for RBC maturation. So, anemia is one of the most important finding of B12 deficiency. Another major area B12 helps is in our neuronal system, and third one will be homocysteine levels. So nerves, if there is a B12 deficiency, you can see subacute combined degeneration can be there, that we'll see afterwards. Peripheral neuropathy can be there, thoracic myelopathy can be there. Patient can have visual loss, diminished vision. Patient also can have dementia. So many problems can occur due to B12 in CNS. Another important problem is homocysteine overproduction. So hyperhomocysteinemia can sometimes can occur due to B12 deficiency. It can lead to arterial and venous thrombosis. Now we can see the B12 deficiency. Most important is dietary deficiency, especially vegetarian diet. So if you are vegetarian diet, if you are taking vegetarian diet, then try to take more milk and milk products, because that contains more B12. So milk products should be added to the vegetarian diet. Then gastric surgeries, total gastrectomy, so absorption will be reduced. Proton pump inhibitors, their chronic use, that can reduce the absorption of B12. Malabsorption states, including infections, chronic alcoholism, then fish tapeworm infestation. Pernicious anemia is immune mediated anemia against intrinsic factor. Pernicious anemia is an autoimmune disorder associated with parietal cell antibodies. That is very important. Parietal cells help you to absorb the B12. So parietal cell antibodies and intrinsic factor antibodies. So that's an antibody mediated destruction of parietal cells or intrinsic factor. So this intrinsic factor, which is secreted by parietal cells, are very important for B12 absorption. That will lead to pernicious anemia. So that can be associated with Hashimoto's thyroiditis, Graves' disease, Addison's disease, hypothyroidism, and vitiligo. Now, clinical features, there are a few important clinical features. We will not be able to discuss everything. One is anemia. So, megaloblastic anemia is classical. Glossitis, smooth atrophic tongue, red tongue during attacks, splenomegaly, jaundice. You see, this megaloblastic anemia will produce large cells. So these large cells will be destroyed in spleen because they are abnormal cells. They will be destroyed. So slowly splenomegaly will occur. Because of this exaggerated destruction, bilirubin will be overproduced. That will produce jaundice. So jaundice, splenomegaly, all are due to megaloblastic anemia and hemolysis. Neurologically, peripheral neuropathy, that is a classical finding. Paresthesia of fingers and toes, because these neuropathy affects mainly large fibers or lengthier fibers, and that starts from the distalmost part of the toes, then it ascends up even after sometimes it can affect your fingers also. Then subacute combined degeneration, mainly in the thoracic cord, they can have spastic paraplegia, along with they can have peripheral neuropathy. So this will be one condition where patient can have spastic paraplegia with neuropathy. So they can have both LMN and UMN type of lesions in the same segment because of the LMN lesion in the peripheral nerves and UMN lesion in the thoracic spinal cord. Dementia, optic atrophy, so visual decrease and altered sensorium can be there. Cardiovascular disorder due to raised serum homocysteine, that is very important. Homocysteine levels are important. So there are many patients you can see that patients developing repeated stroke or MI, especially smokers. If you see the homocysteine level, homocysteine will be very high. If you treat with various drugs, this may not come down. So you have to treat with B12. There is a treatment. Okay. The subacute combined degeneration is mostly due to B12 deficiency. The degeneration is mainly in the dorsal column. So patient can have spastic paraplegia. Legs, arms, trucks, progressive tingling numbness can be there. Visual impairment, change in mental status, spastic paralysis, sensation diminished in the peripheral area can be there. Babinski sign can be present. Extensor plantar reflex. Romberg sign is also seen because of the peripheral neuropathy. Now, one of the most important, so any patient who is having anemia, you can see HB will be low. HB percent will be low. But you look at the MCV, MCH, all these things. If MCV is high, then it is due to a larger cell anemia. Mostly it is megaloblastic anemia. So if you see the MCV, if it is more than 110 or 115, then you have to confirm that it is mostly megaloblastic anemia. Then you will see the peripheral blood smear. In peripheral blood smear, you can see the cells are larger. The RBCs are larger than comparing with the normal RBC. Okay. Reticulocyte count, RBC count are low. Pancytopenia can also be there because this B12 deficiency that can produce total reduction in the bone marrow production. So anemia can be there, neutropenia can be there, thrombocytopenia can be there. So all these findings can be there in patients who is having B12 deficiency. But the advantage is actually bone marrow is suggested here. But if you give B12, immediately within 48 hours you can see the response. So you can avoid bone marrow study in this type of patients. But if the patient does not respond to injection B12 or folic acid, then you have to go for bone marrow study because there are other reasons for pancytopenia. Peripheral smear may show anisopoikilocytosis, erythrocytes varying in size and abnormal shapes, macroovulocytes, these are all abnormal cells, hypersegmented neutrophils. That is one of the classical finding you get in pancytopenia due to megaloblastic anemia. Neutrophils with more than 5 distinct lobes is in megaloblastic anemia. Neutrophils with less than 3 distinct lobes also can be seen. In adults, common cause for macrocytosis, macrocytic anemia are alcohol use or abuse, liver disease, thyroid disease, and Megaloblastic anemia like B12 folic acid deficiency. Hemolytic anemia is also seen in many patients because these cells are larger. They will be destroyed in the peripheral circulation or spleen. So you can see here peripheral cells, hyper segmented neutrophils, larger RBCs. Okay. So bone marrow may be required in B12 deficiency anemia, but normally in B12 deficiency anemia, we don't do bone marrow. We give B12 injections. Don't give tablets because if there is an antibody which is reducing the B12 absorption, it will not act. So give B12 injections. You can see the response in 48 hours. Patient yeah, production index, RBC production index, you can see it is increasing. So routinely we don't do bone marrow, but if you are doing it, you can see the increased production in the response to peripheral destruction of RBC. That will be seen. Megaloblastic or erythroid cells, larger cells, marrow iron is increased because it is not due to iron deficiency anemia. Giant metamyelocytes, dysplastic megalokaryocytes, all these things can be seen, but normally we don't do it. Other lab investigation, bilirubin will be elevated because it's a hemolysis. Indirect hyperbilirubinemia can be there in many patients. Larger cells are destroyed in spleen. That is the cause. LDH is always elevated in hemolysis. Any hemolysis, if you see, LDH will be elevated. B12 levels will be very low in many patients because either it is not absorbed or due to decreased intake, or there is antibodies in the stomach which prevents the absorption. Schilling test can be done in pernicious anemia. Nowadays we don't try to do this because even if you do this test, the treatment is ultimately injection B12. So in a normal setup, we don't try to do Schilling's test, but in an academic center, we can go for Schilling's test and find out what is the reason for anemia. But these tests are very costly and difficult to do, so we never try to do all these things. If there is a suspected B12 deficiency anemia, give injection B12, because even if you diagnose pernicious anemia, the treatment is again injection B12 only. So B12 injection, it is there are some different regimes given in different books. One of the easiest regime will be you give 1000 microgram per day IV for 1 week. Then 1000 microgram per week for 1 month. Then 1000 microgram per month for 1 year. Hereafter, you have to give yearly 1000 microgram, and you have to do the B12 levels always. Okay, we can try to give oral tablets, but sometimes it will not be absorbed. So never try to give orally initially. Try to give injections initially, because once there is subacute combined degeneration or dementia occurs, it is not completely reversible. So whatever damage has occurred, that damage will persist. Only thing, you can arrest the progression of the disease. So to prevent the damages in the neuronal system, you have to give it fast. So always we give as an injection. Then along with injection, we can continue oral tablets also. So that is very important, especially when you are having one entity called as pernicious anemia. And we are not investigating for that. If you are investigating for that, if there is no pernicious anemia, you can continue oral tablets. So you can see the reticulocyte response, reticulocyte production index. Within 48 hours, you can see that it is increasing, and your neuropathy will respond very slowly. 6 to 12 months it takes, but some patients develop faster relief from the symptoms. Now this is Schilling test. I am not going to the details of Schilling test. You can read about this because it's beyond discussion in scope in emergency medicine department. But this is a test which can be done in patients who is having intractable B12 deficiency. B12 is not getting absorbed with a lot of complications are occurring. So we can do this test in routine medicine wards. But even after this test, the treatment will be injection B12. So we don't try to do this because it's a very difficult test to do to be done in emergency departments or ICU. So we have discussed about one of the important clinical scenario, that is B12 deficiency. Our country, it is the incidence is very common, maybe because of complete vegetarian diet. If patient is taking vegetarian diet, even then we can avoid B12 deficiency, because milk and milk products contains large amount of B12. So advise them to take more milk and milk products if they are completely vegetarian. If they are vegetarian, non-vegetarian, then meat and meat products can increase the B12 deficiency. However, when we are diagnosing B12 deficiency, it is better to give injection B12 initially than oral tablets, because we don't know what is the reason for B12 deficiency. It can be various reasons. It can be including antibodies. If it is due to antibodies, even if we give tablets, it will not get absorbed. So injections will be very useful. Methotrexate can produce folic acid deficiency. One of the important cause for folic acid deficiency is methotrexate. So when we are treating with methotrexate, always give folic acid. Otherwise, patient can develop megaloblastic anemia. So give folic acid. If the patient develops neutropenia or anemia, give folinic acid. That is very important. It's an active form of folic acid that has to be given. Leucovorin is the brand name. So we have discussed about one important clinical scenario, that is megaloblastic anemia. Thank you.